Prepare your pens and notebooks. Exciting things are coming. So looking forward to great discussion and great interactions. So just in 1, 2, 3, maximum 5 minutes, we will be starting our session. Thank you. Again, colleagues, a very good morning to you all, and a very warm welcome to the 12th Tanzania Health Summit, but a much warmer welcome to the UNICEF Forum. Today, all of us, we would agree, we're sitting in this room, but we appreciate the rapid pace that technology is advancing in the world. And it is imperative that we maximize efficiencies across the whole board of the healthcare system. And I think at this particular moment, scaling up digital health systems is not an option. It is a need that we need to realize if we are to improve quality of care. Understanding that and recognizing that, UNICEF, through this forum, wishes to have a session with you to present, to share, to discuss on a number of things, so that together we can realize the bigger picture of improving quality of care by leveraging digital health systems. And we will be having a session with you today, and it is a very exciting session, as I've said, and it's going to be conducted with very exciting people. I see one on my left. And I will be your moderator today. And my name is Dr. Shali Zumba Moshemele, and I work with UNICEF. In our session today, and amidst us, we have, I think, 7 people. And we have a very exciting, brilliant, I don't want to sound like a feminist, but we have a lady amidst us, our very own, our keynote speaker, none other than Professor Tumaini Nagu. A big round of applause, and allow me to welcome her. This is not even a podium. Welcome her in front of you. Karibu sana, Professor Nagu. May you have a seat next to me. And just to say a little bit about Professor Nagu. She was actually my teacher when I was doing my medical rounds at Muhimbili. But she brings in 20 years of experience, being an academician, being a clinical practitioner, but a global health expert. And for those who may not know, she was also previously the CMO for the Ministry of Health, but currently serving as the Deputy PS of Health at Pure Ralj. So if you don't mind, again, exciting people in the room, we do have Silvano Silomo, the Director of ICT from MOH. A round of applause for him, and Karibu. We also do have Dr. Innocent Mahagama, the DMO from Buhigwe. Karibu sana. We have a very active, energetic, vibrant man. For those who have done AFISS, you may never miss this name, and this is no other than Chris Ogon from the Health Quality Assurance Unit. A big applause, colleagues, for him. And we have 2 people from Zanzibar. We have Nseya, and we have Mr. Mohammed. Big welcome. They've crossed the ocean to be here. We have the Director of ICT from Pure Ralj, Eric Kitali, but unfortunately, because of competing priorities and responsibilities, he sent us a guru, a digital health expert, a man of many skills, no other than Mark Tanda. Colleagues, we will spend the next 1.5 hours to share with you. We will have a presentation for you after our keynote speaker has presented, and kindly just I think the setup may be a little bit uncomfortable for those on my left and right, but the screens on the left and the right will be displaying the information that is actually being presented here. So for those, if you have neck issues, I suggest you just concentrate forward, but if your neck is very flexible, you can turn left and right, and then you can see. So the session today is focusing on scale-up of routine digital health systems, and with the mind that if we are to improve quality, information, data is critical. Are we still in the era where we have to write multiple papers to be able to provide care to the same patient? We have to fill 20 plus books to be able to. Are we ready for change? Are we ready for digital systems to enable us to be more efficient, to maximize the use of our time so that we do not treat the papers, but we treat the patients? So the session today is beyond innovations, realizing the potential of scaling up routine digital health systems for high quality care in Tanzania and in mainland. As you know, we are the United Republic. We are one, Zanzibar and Tanzania Mainland. So to kickstart this session, allow me to welcome Professor Nagu as our keynote speaker to start her session. Karibu, Prof. Kindly note that we will be displaying, the person who is displaying the slides, kindly move the slides to the first slide where we will have the bio for Professor Nagu. Kindly move. You have already noted me. That is Prof. The next slide, please. Welcome, Prof.
Thank you very much, Charlie. It's really both an honor and privilege to be in front of this distinguished panels list, and I think the panelist, I would say, is much more knowledgeable than myself, having been born before computers, but I'll try to just instill something. But I think the aim of my session is really not to, I'll try to stand here so I don't fall down and break my legs now. The aim of my session really is to stir up questions more than answers, to keep us all thinking, to provoke your thoughts on the issue of digital health. As Charlie said, now we are in the era of technology. Our Vision 2050 also puts technology at its core, but also, you know, if you do not embrace technology, then you're left behind leveraging digital technologies in health. And if you want to speak about health, I think we are about 5 years, maybe less 5 years towards 2030. And we have to speak about our sustainable development goals, where everybody thinks now it's a right to have quality of health, health for all, right? And so if we're talking about quality of health, we put universal health coverage at the center. And the center of the core of universal health coverage is primary health care. And I think that's why it is really befitting to talk about improving quality of care, embracing technology in primary health care, just to set the stage. But also we know in Tanzania that like 95% of our population get their health care from primary health care. And when we talk about the number of health facilities, we're talking about more than 98% of health facilities are at primary health facility, primary health care. And so you should, I think it's really important, once we improve our health, quality of health care in the primary health, then we're good to go. We reduce referrals, and we improve the health outcomes significantly. Now, this slide really talks about the few indicators of quality of health. Now, those of you who know or who are gurus in health and quality of health, you'll know there are parameters of quality of health as stipulated by WHO. One, the first is safety for all reasons. Safety, effectiveness, equity, efficiencies. We're talking about timeliness of healthcare, but we're talking about also patient-centered care. If we provide the care, it has to be right care for a particular patient. It could be the same diagnosis, but different care because patients are different, and that's why we're talking about healthcare. Now, in the context of universal health care, the first thing is access, and I would like to speak about access to care. How digital health can strengthen access and equity of care. You know, now with digital health, we can speak about telemedicine. To go to doctors to find care, they could call, they could go online, you could go to telemedicine, virtual consultation. And when we're talking of Tanzania, with and summer, many patients, give them access and equity in terms of health care, and therefore address universal health coverage. And so I think this is number one that I would like to speak about when we're talking about health care. I'll draw your attention to maybe 2 or 3 things. The first is when we talk about can you hear me? I think we can hear. The first is, we know, number one cause of errors, of mortalities and bad outcomes in the world is medical errors. Now, when we embrace technology, we're thinking we're also improving or reducing, minimizing errors. And these errors could be in terms of prescription errors. If we embrace very well technology, you could have drop-down menu, for example, if the diagnosis is malaria, what are the options for malaria? Now, you limit doctors to a certain number of medicines, and therefore, you reduce really transcription errors from one healthcare provider to another healthcare provider. And that's another layer of reducing errors and improving patient safety. I think that's very new. A source of error from one healthcare provider to the other. Now, digitizing everything from patient registries is very key to health system. There are several clinical diagnosis or clinical treatment or management tools that you can embrace or you can enhance in your system, be it for diagnosis. There are some AI that you can employ this and put the standard treatment guideline in our health system. And therefore, we limit our doctors because that's what we know, but they can also use other clinical support tools to make a diagnosis or to treat the patient. So for patient safety, really, I would like to, really, if you forget everything, just remember we can embrace technology and help us to reduce errors, to improve our clinical management and the like. When we embrace technology, we enhance our efficiencies, but also improve our reporting in terms of timeliness, but also in terms of the quality of the reports, yeah? So we don't have to have our clinicians or healthcare workers to go, and that would save time, but also it would increase efficiencies because that would also take the time of these healthcare workers and shift it to more meaningful duties that they're required to provide. And so when we talk about this, I think one issue is quality. But if you want to enhance quality in Tanzania, where we have a gap of close to 50% of healthcare workers, we have to think about the carers, yeah? So carers are important in terms of the health system. Human resource for health is one important pillar of the health system. And so if you reduce the burden, reduce the time that shift their focus into more meaningful things, then I think you're improving quality, but also you're improving their qualities, and they become even more happier to address other issues or other tasks that are important. I think I talked about efficiencies and resource optimization. The last is patient-centered care. I usually like to speak about patient-centered care when I talk about quality of health, because everything has to focus on a patient. Nothing makes sense if it does not focus on the patient. Now, when we think about this, if we embrace technology, we can think about many options for the patients, including what I've talked about. I was talking to a physician the other time who said, I saved a patient from myocardial infarction at the height of Himalayas, just using a phone call, WhatsApp call. Now that can be even better. In Tanzania, we know we have telemedicine, we have our zonal hospital and national special hospitals who are helping regional hospitals and some of the district hospitals. We have more than 30 ICUs, experts. We know we do not have enough experts for all these ICUs, but we know we can be at Muhimbili and monitor a patient ICU and its monitor in Sumbawanga, for example. I've stayed in a facility where a clinician or a nurse stays in one supercomputer at a referral hospital and manages 10 patients in a district facilities. Why not possible? This is possible. So when we embrace very well our technology, we can enhance our efficiencies, we can reduce time, we can also improve our patients' outcomes in terms of giving them the right medication or the right monitoring. And the patients may choose to be where they are and have their care wherever they are. I think this is really important that I wanted to touch on. The last is when you have data, that will support our continuous quality improvement. So one of my best friends used to say, to improve is to change, but to have quality improvement is to change often. So you have to change often, and how do you change? You have to be informed by data. And so I think in the next 1 hour or so, this esteemed panel here will show you how Tanzania has moved into embracing this technology to enhance efficiencies, to improve patient outcomes, but also to reduce workload from our healthcare workers. So this is just what we have done at primary health care. The first is the famous Got Home is thanks to UNICEF, and that's, we've been working with UNICEF very, very closely to have Got Home is. And as I say, to improve is to change frequently. This started 2012. It has gone a lot of modification and improvement, and now we're talking about more than 6,000 facilities throughout Tanzania having Got Home. So I think this is really important to highlight, and this is almost 100% of all our facilities, yeah? So I think this is really a big milestone. The beauty about Got Home is that it has an offline and module as well. So whenever the internet is not connecting well, then they can use offline module. But also we have the mobile Got Home is version for healthcare workers who are going to do outreaches or special assignment. They can still use, and therefore patient will still be counted in the health database. Yeah, no data will be lost. So that's the beauty, that it can be used in different settings to suit our Tanzanian setting. Yeah. We also have facility financial accounting and reporting system, the second in yellow. Now this is implemented in 7,000 plus facilities, primary health facilities. What this does is, it's, I think I'll talk about facility financial accounting reporting system in tandem with the plan rep, because the cycle starts with planning. Now you have to plan to be able to spend, right? And you will only be able to report what you have been able to plan. And so nothing comes in between, right? So this enhances accountability. It also improves efficiencies as well. We have this AFIA support system. We have Christosom here who will be able to talk a lot about it. And what is the importance of this? it helps us also to improve all the time. This is the support supervision tool. We also have, so there are other digital tools that the Tanzanian health system has, which are interrelated or interoperable with the GoToMIS. Some are really not interoperable. And so I think this is something that it's work in progress. We have to continue. For example, I'll just cite one. One of the key important features in health system is health commodities. All of us know. Without health commodities, you'll not be able to provide health services. Now we have the ELMIS, yeah, which reports and requests health commodities. Now these health commodities will be used to treat our patients who are registered in GoToMIS, right from registration, patient to consultation. Some go to labs, others will not go to lab, and they'll go to pharmacies. Now prescriptions will be done in GoToMIS, but you cannot track really the stock movement now between ELMIS and GoToMIS. And so this is a gap that we know, and it has been worked upon. Thanks to American government, I think some are working on it already to enhance this. And so this is really a cycle to show you that we have embraced technology to improve our health system. Now finances is also a key pillar in health system. With data, with information, we can be able to allocate well resources in the right places, because then we know where the burden is and what resources are needed. I think this is a slide that I've talked about really in the first slide, but maybe the only thing that I'd like to talk about in this slide is the continuum of care, yeah? With GoToMIS, we're able, to record patient, but also to refer patient to the next level. And I think this is really key in terms of patients follow-up. There's some work to be done to perfect the system, but I think this is really a great step. Next. Right, what lessons we've learned? Many lessons, and many are yet to be learned. The first, I think it's important to engage. Sometimes internet is not working, so the offline module is there. Sometimes they're going out and where there's no electricity, so the use of solar energy in some of the places I've gone, I've visited, for example, in the coast region, remote areas, internet is not accessible, is not available. And so these are also some of the hiccups that we're trying to reach, where when all facilities everywhere in Tanzania you have internet and connectivity, then this would be great. Continuous training and capacity building. We have healthcare workers of different level of understanding, and so it's important to everyone and to give them support as need. And this is key, and following feedback, the Department of ICT and DHS, the Department of Health and Social Welfare at the PORAJ, formed regional and district teams, which are there all the time to troubleshoot in case of a problem. Sometimes it's just a few things that you need to fix, and the system will continue. And so these teams act like support systems, support teams to the district teams, to the health facilities wherever they are, to ensure that there's continuity of care and the system operates at its best. Regular monitoring and improvement. We monitor the system. Now the good thing is we can see. Yeah, we have several modules of GoToMIS. According to the level of facility. You have dispensary. Dispensary does not offer all the services that you'd find in a health center or in a district hospital. And so the modules that health services, they should be able to offer that facility. Now the challenge is, yes, you'd have GoToMIS at a facility, but not all modules are used. And so we continue to monitor and see if there's a module that is not utilized at a particular facility, and we see what are the challenges and troubleshoot as it goes. Yeah. Next. Right. So I think I've talked a lot about health, digital health in the primary health care. At the surface, the details will be spoken by our gurus here. What is the way forward? I think the way forward is best from this forum, but I'd like to highlight to the data that we find. In Tanzania of healthcare workers, now the challenge is you might not, two different facilities may not be similar in terms of the workload. For example, take two district hospitals in urban and in rural areas. They might not be similar in terms of their requirement of human resources just because of the workload that they have. And so I think we embrace this going forward to ensure that first, all of our facilities are covered. Not only that, but all modules are utilized as per level of facilities. Last, which is very important, is to ensure interoperability between, to enhance interoperability between systems. For example, as I said, ELMIS and GotHomis, but a lot of work has been done already in plan prep and facility financial accounting and reporting systems and GotHomis. Now we can tell how much has been, we can tell financial status of the facility by just looking at the GotHomis. And for those who are not using GotHomis utilizing collecting cash, then we can be able to say why they're not using that. And we have, there's interoperability between the government systems, GPS and GotHomis, and therefore it's really easy to track finance ability and to make sure that all this revolves around quality of health. Thank you very much for your attention. I hope I've been able to thank you.
Guys, a much bigger round of applause. Thank you so much. So many kind words from Professor Nagu. And time is of essence. I just want to capture a few things. Over 6,000 facilities in Tanzania have GotHomis in place. She has mentioned of issues around efficiency, accountability, and quality of care. Allow me to say nothing changes when nothing changes, and that is a fact. If we don't change, nothing changes. So if you can take anything from everything, she has said nothing changes when nothing changes. We have to embrace change one way or the other. So allow me to welcome the next, it's not even the next, it's actually the first panelist. And it is no other than Mr. Silvano Silomo, the Director of ICT from MOH, and a seasoned analyst who has taken part in transformative changes when it comes to digital space in Tanzania. He will talk to us about the digital health strategy that has ended in 2024 and the one that is coming until 2030. But humble me, guys, if I become a bit more strict with time. I will be giving 5 minutes only to all of us, so that we could have time for Q&A. So Silvanus, karibu sana, 5 minutes are for you.
Thank you, moderator. And I think it's high time today to crown our professor, our only one professor, Tumaini, to be a digital health guru. Thank you very much, because I see like she preempted us. What are we going to talk? Going back to what I've been asked with the moderator, all that has been mentioned by DPS or Professor Nagu is has been set some regulatory frameworks that govern implementation of it. So from the ministry side, as a policy maker, we do develop some guidelines and strategies to ensure that these digital solutions are deployed effective as according to the requirement that has been raised from the grassroots. So we have developed what we call a digital health strategy. I may maybe say thank you very much to UNICEF and the team for being part of this by supporting development of this strategy. The first strategy was 2013-2018. Basically, we developed the first strategy with very big, ambitious goals. We didn't look at the condition of the infrastructure that we have in country. So we do like having an objective or strategies that we want to deploy, which are more big than the nature of the infrastructure that we have. So we developed the first strategy starting 2013, 2018, and then we come to make an evaluation of it. We see like we score like 33% out of 100. And basically this, because it was our first strategy, so we see like it's time for us, it's high time for us to start learning on how are we now going to improve, where did we fail, so that we can start up again and creating some new mechanism that will make us to make more score with the coming strategy. So coming to 2019-2024, we do develop again another strategy, digital health strategy, of which we do score like 51% is a completed objective that we have been mentioned in our strategy, but we do like 33%, which are partially employed. So you can see, if you take a total of that 50% and 30%, we do employ like 80 of the previous strategy, and then we do evaluation of it, so is an informing tool to the coming strategy. So reaching 2024, 2025, 2030, we do develop another strategy which is highly supported by UNICEF and the team, and D3 and other stakeholders, key stakeholders, supported us to develop this strategy. And when we assess the previous strategy, we find like we score the same that we have been scored the previous strategy. So we see like we are moving because the government has been started to address some issues with infrastructure, issues with the human resource, issues with the capacity that has been mentioned by Professor. So there are a lot to make sure that we are supposed to come in touch so that we can deploy our strategy as successfully as we can. So for now we have this new strategy, which is starting 2025 to 2030, and we add some new initiative that were even not available in the two previous strategies, like coming of these new innovation like artificial intelligence and the stuff. So we tried our best to make sure that we accommodate all these new coming technologies so that we can be in a position that our strategy is robust to ensure that we capture all a digital aspect. So our new strategy is not yet signed, as I can tell right now. It's in our permanent secretary office to be waiting to be signed. So maybe we expect within like 1 or 2 coming week, the strategy will be published, so everyone will have one copy of it. So maybe to summary regarding to strategy, it really helps us a lot. Because, it starting at the level of the PHC up to the national level, you found like partners started to work in silos. But after having the strategy, then we do develop a custody action plan for the strategy. So we set a mechanism for the partners to align to the custody action plan, so that when the partner coming say that I want to maybe to invest in this area, now we are telling him that this area has been invested with another partner, but there are these other areas are not yet established by any partner. So it was really helpful for us to make a good coordination of our partners so that they can work with alignment of what government, what's supposed to deliver. But also we have what we call blueprints of digital system layout in country, which is called an enterprise architecture. This is a document that we do develop to make sure that what has been made a touch with the Professor Nagu regarding to interoperability, standardization, and the stuff are kept in place. So we develop an enterprise architecture document which is now governing the deployment of all digital system, starting from the level of the PHC up to the national level, to make sure that we avoid this kind of having silos implementation in the country. Because if we found like in most of the sectors, one of them which with a lot of digital system is Ministry of Health. So we have been told that most of the time that you have a lot of system. So now we found out a mechanism to make sure that we have few system interoperable so that we can have better efficiency to make sure that healthcare workers, decision makers are getting what they want, so that we can have a good kind of provision of healthcare services. But also we came to realize that after deploying digital system in ground, we really need to have mechanisms to make sure that we secure our data. We know that we have a lot of data that are produced in the ground, so we have to make sure that these data are safe and could be shared in a manner that are not misused. I've been knocked here with the moderator. We have a lot to talk about, but the time is not enough. Thank you very much.
Silvanus has done a lot for this country, and a big round of applause for the summary of 20 years, 10 years. Thank you so much for that great presentation. If I could take anything, duplication, so many systems, alignment, partner coordination, that is the future that the Minister of Health envisions. Thank you so much. Now, the next panelist to speak was supposed to be Eric, but now we have Mr. Tanda here. And because you are very quick, I'm only going to give you 2 minutes. Yes, I've heard from Pure Raj people you are very quick. So 2 minutes for you to talk about functionality and scale of primary healthcare systems.
Thank you. I'd like first to say thanks to Professor Nagu. You know, she has done a lot, she said a lot, she played a lot. But also, I will not let this go without saying, you know, I would like to recognize the presence of my daughter, Trace Mark. Could you please rise up? Yeah, that's my daughter. Yeah. So I've given 2 minutes, and I think now 10 seconds have gone. You know, that's just the journey of GoToMe's. We started with an EMR, electronic medical record, but currently now we are with the EHR, electronic health record. The difference is that with an EMR, you just destined to one particular facility. But with the EHR, electronic health record, then you are sharing health information across facilities. And currently we are on 6,066 health facilities. Next slide, please. So those are the modules that we will have within GoToMe's, you see. And for that, you know, it helps with the continuum of care, the care coordination. So because we know the HIV client is the one who is going to get malaria. So when you send the data from the CTC to OPD, that proves the care coordination. Other slides, please. The integration landscape, of course, our system is interoperable, and we're using a lot of standards, like LOINC, the logic observation, identify names and codes for investigations. We have SINOMED, standardized nomenclature of medicine. We are using our FIRE standard. We have HL7 for connecting with medical equipment. And when we say GoToMe is interoperable, you know, because the difference between integration and interoperability is when you are doing integration, that means you have a third part in it. The one system speaks, it goes to the third part, and it translates to talk to to another system. But with the interoperability, you are talking about agreeing on standards. How are we going to exchange this data? So GoToMIS currently is very interoperable and has integrated with a lot of systems. You could see CRVS, the Civil Registration Viral Statistics, so we're sending birth data plus the death data. Also, GoToMIS is interoperable with the AFI-HMS through HDU, the Health Data Universal, which acts as a health information exchange for us, and acts as the master patient index for the nationwide. So we are sending referrals from PHC currently to RRH. We have seen the medical equipment management is there. But also with GoToMIS currently, we have three solutions, as Professor Nago have said. We have an offline solution. We do have centralized GoToMIS as itself. We do have a retrospective data entry that you're capturing data on paper when there was a lack of electricity, and then when electricity came back, then you're entering back the data retrospectively. But also, she spoke about doing the virtual consultation. We do have the digital health wallet right now. So you can do appointment. A client can view medical records, but we have clients with the like diabetes or stuff. You could do request a refill from any of the facilities. So, and right now we are working on making sure we are connected with the WHO digital health, global digital health certification network, to make sure that when you are using your digital health wallet, the patient portal, when you go across countries, then there's no need of showing up with the paper cards for yellow fever or something. You could just show up with your medical records from your application, and then you could view, everything that happened to you, including vaccines. And currently, we have already integrated with the TIMA, the TIMRI, the Registry for Immunization, which with that, the application is working in private hospitals, but within the PHC, we have GoToMIS with that module. Currently, we are sending data bi-directional. So any client who is being vaccinated within GoToMIS, the data will be seen in private hospitals. And any client who is vaccinated within the private hospitals, the data, all the longitudinal data of the client will be seen within GoToMIS. So I think you have given me 2 minutes. Maybe I should talk about the global standard a bit for half a minute. We're working with the WHO also with the SMART guideline, with the 5 layers, the narrative layer, which looks into guidelines. We are working with the operational layer for digital adaptation kits. We are working with the machine readable for developing of algorithms, but also we are working with the execution, and then in the dynamic part. The dynamic part is when we are going to hit on machine learning, and we're also going to hit on AI. So we expect to have some components of AI within our EHR, like the ambient scribe, that there's no need for a client to speak with a health worker, a clinician, and the clinician writes the notes on papers. Rather, the clinician should concentrate on a client, right? So with an ambient scribe, you could talk to a doctor, and the system captures what you have spoken, and then transcribe all the conversations, and it gives you a decision to make, helps you to make a decision for the clinician. So that's what we are doing, and we also want to connect with the IoMT, the Internet of Medical Things, like the Smart Vitals and the stuff like that. So I think I have been given a very few minutes to talk about, and I think I've, can do more. Thank you very much.
Tanda, if you can just keep the mic, we'll give you an extra 0.5 of a minute for you to finish your last 2 slides. So you had a slide before conclusion. If you can go back, yeah, so we can give you some extra minute. Yes, you are here.
Oh, I think so. I should go close. Sorry. So this our way forward is to ensure effective use and optimization of GoToMIs. Right currently we're on 6,666, as I've said, but also to scale out new GoToMIs modules. We have some modules which haven't been used that much. For example, immunization, the HTS, the HIV testing services, the CTC, TB and leprosy. We have the prime vendor, which is currently now used. For this, we have integrated with the ELMIS, as Professor Nagov said. If you are ordering medicines from MSD and there is out of stock, we have those vendors within our regions who are supposed to do this. So we get the out of stock notification from ELMIS, and from that, it triggers to order from prime vendors. But also we have integrated with the FAST. With FAST, we go and see how do you have actual fund within FAST so that you could order to the prime vendor, and this to avoid the Mikopo and the Stati hospital. So this has got some limited number of services, because we know it has to be to do a little. Strengthen the interoperability with the DHS2, HDU, HLMS, but also, we have integrated with our feedback system, Afya Yetu. So when a client goes to a facility and they use GoToMIs with the messages to give feedback. And then to invest in infrastructure, this is a big cry, we know this. Because you could find service points which have this infrastructure, and to maintain policies for private security. And we still have management is a problem here. We need when a client goes to a particular hospital, she has to get medical. But currently we are using the medical record number. The next, please.
I think a number of things for us to take away. For those who have had the thinking for the longest that GoToMIs is only for revenue collection. That is it is an EHR?
Yes, and can I finish one thing? Doctor, sorry, about the telemedicine, how it works, the EHR telemedicine, how it works. For example, you have taken an ultrasound to facility A, for example, Mbagala, and you really don't have a sonographer who could read and make good interpretation about that image. You could send that, the same picture to Sinza HC or to Korogwe District Hospital. And then the sonographer at Korogwe District Hospital could look at the picture and read and give back the interpretation to Mbagala.
That is amazing.
Yes, asking this client to move.
Tanda, that is amazing.
Yes.
You will have more time. Round of applause for Tanda, guys. It's the part in Tanzania, you can make your appointment. You don't need to go to a hospital. And it is all happening in primary health care. I've always heard of an internet of all things. Now we are here so that we could have time to discuss. And the next speaker is none other.
So we formed a team that had some members of the CHMT would be supervising. And we also decided that we will roll out this starting the month of April to May, and we'll use the devices that we have, we'll use WhatsApp groups. It's definitely with a collection of 50 million to anything. So starting April, we had our plan in place. We had our WhatsApp groups. We had our team for supervision formed, paying per diems to people coming to training. So we thought on a way that we could do it with minimum cost, zero if possible. So we used the hub and spoke system model to do the training of the staff from each facility. They were then brought to the hospital. The hospital, we had a piloted area and almost everyone was comfortable. They were trained there, the IT within a week, super users. The people who learned very fast were very lower level, but also to train the dispensaries within their catchment areas. So
Dr.
these dispensaries,
your time is over, so I'm giving you half a minute.
Okay, so these dispensaries we are satellites to the health centers, and then the health centers were the same used as training centers for the dispensaries. By the end of May, we had completed the training, and we gave ourselves 2 months for mentorship, supervision, because we were thinking of the risk that they would go back to the paper-based system. By the end of July, we had completed the rollout to all the health facilities that we had, and that's when we started sharing our success to everyone else and learnings, and that other people could do the same if it was applicable to them. So this is how we implemented. Yes, we had challenges, we have had achievements, and we are in progress, but if I have some more time, I'll have time to share that. Thank you.
Thank you. Doesn't the applause need to be light? When Obama became the president, and he said, the change we seek. You are the change you seek, and that is very evident from Dr. Mwagama. Changes starts with us. A big round of applause for him, guys. We now welcome the last but one panelist, Dr. Chris Ogon, and I will be very strict. It's going to be a minute for you. Kindly go straight to the slide that is, can you move that slide? Can
Thank you very much, moderator. 1 minute is very difficult to manage. So I'm going to talk about the Afya Supportive Supervision System, a supportive supervision platform which was developed in collaboration Ministry of Health, PRAG, and partners. We developed the system in order to counteract the challenges which we are facing in the supportive supervision. For example, issue of coordination. Most of the time you see people, 3 people going to the council or to the facilities without knowing each other. So we developed this system so that we have a good coordination from preparation, during conducting supervision, but also after conducting the supervision. So this is one of the issues. Other one was about we have a lot of checklists. Everyone was using the checklist. So we harmonized the checklist, and that one has simplified the supervision, but also the issue of follow-up of the action plan. Normally, when we are using this paper-based, normally we are using the Mtuha Book 2, I think most of you knows that. You just write, and when you go out, this one was launched in 84 councils in the country, using the system for conducting supportive supervision system in the country. And currently we are envisioning to scale up to the facility level, to make sure that those action plans are being acted upon by the facility in charges and the staff from the facility, so that to complete the cycle of supervision. After developing the supervision, so we have some of the issues we have made improvements. We have currently we are in the version 3 of the system, so we have improved. In 2021 was version 2022 we improved to version 2, and currently version 3, and this was supported by UNICEF. Also, we are in the process of revising, in the final stage of revising the supportive supervision guideline, so that we have to go to digital. So we have changed the system to digital. The guidelines we have was on the paper-based, so we have to revise the guidelines so that it can be in line with the developed supportive supervision system, which is digital. Also, we have developed some checklists for PHC. Currently, there are a lot of checklists we have developed, but currently we have developed a PHC checklist, which is used by the CHMT, because they are the one we are expecting to use the system for supervision. And also, maybe one thing I can say that we have almost around 300 checklists. We have users. We have trained around 300 users directly from the ministry support and the other partners. But also there are other trainers who have been have got the on-job training on how to use the supervision. Also, we have around. Okay. So I can finalize by saying that the issue of collaboration with partners has helped a lot to to scale up this supervision. We have a lot of partners who have supported the system, and we have improved the use of data currently. As you can see the dashboard, you can see every time, this is a dynamic dashboard, you can see there, you can see it at each level. If you are CHMT, if you are Ministry of Health, you can see the data very. Thank you very much, Madam.
Thank you very much, Chris Ogon. A big round of applause for him. Afya SS for completing the supportive supervision cycle. We supervise, but we want it to be a completed cycle. I want to welcome our last panelists to speak, Nseya and Mohammed. Over to you, Nseya and Mohammed. I'm giving you, because you guys came so far, I'm giving you 1.5 minutes to tell us about the evolution of the digital health in Zanzibar. 1.5 minutes for you guys, because you've come from far.
Thank you so much. I'm told to talk about digital health evolution in Zanzibar. Imagine we have started from 1990s, and I'm given 1.5 minutes. So, and we are adapting co-creation, co-development, and co-implementation. And because of that, I'll not do it alone. I'll do a co-presentation with my colleague, Nseya. So, before 2020, Ministry of Health approached a kind of ad hoc implementation of systems, which has a lot of implication in terms of duplication of efforts and resources, and duplicated data collection tools that's compromising health decisions. You know, data are important for health decisions, but 2020, we developed the first Zanzibar digital strategy, which gave us a way of how best we can implement a digital system without causing duplications of efforts and resources and duplicated and mismatched and compromised data. So there are a number of systems being developed. I'll not using an EMR. Going up, we have another electronic medical records at the district and regional facilities. And then at the top level, we have also EMR. So let me give it to Nseya to talk about ZanEMR so that we can concentrate in that. Thank you.
Nseya and Mohammed are symbolic of the union. One is from mainland, one is from Zanzibar. So Nseya, 1/2 minute for you.
Wow. Yes, I will just go straight to what we did with UNICEF. We're implementing a project. It's called Tanzania Maternal Child and Investment Program, which is under World Bank, and UNICEF. We're implementing partners. Together, myself and 3 of my colleagues, we are stationed in Zanzibar at the Ministry of Health, and through that, we've been able to co-develop all these digital systems. And while we're doing that, we are strengthening the digital health ecosystem. As Mohammed has said, we have the digital health strategy, but one of the challenges that we found, we have multiple fragmented systems. So before we started the ZanEMR, we had to do a landscape analysis where we looked at current structure and systems, and collaborated with partners to make sure that whatever that we are doing in ZanEMR has improved the services, but also have all the business process, all the issues that needs to be addressed at the facility. That means you remove fragmentation of the system, remove multiple solutions at the facilities by improving the Zanzibar Health electronic medical record. So with that, because you've given me so short time, Tanzania Maternal and Child Investment Program, which is currently being used, and they've just did supervision by using this digital platform to 8 facilities. And if you go next, we also have Zanzibar Afya Maoni, which is a feedback system that linked our patients. As we know, we are implementing the patient-centered care, so you have to know what is happening after the patient has received these services. And if you go just after that, I want to talk about interoperability, because to remove fragmentation, you have to interoperate and integrate systems. And before you do that, you have to integrate people. So our approach is co-development. We sit together with our team at the middle. We have weekly meetings, all digital health implementers sit together, discuss how can we integrate our platforms into one, so that our healthcare workers can have more relaxed way of providing services. Surely you've given me so short time to talk about all of this, but I'll just pause there. But key point here is co-development, co-creation is the key to have sustainable, scalable solution. Thank you.
Thank you. Isn't that powerful? co-creation, co-development, key in sustainable, scalable solutions. A big round of applause for Nsea and Mohammed. We have 12 minutes with us. The session is planned to end at 12:30. We started a little bit late because I think the previous session had taken 10 minutes from us, but we would like to keep time. We had questions for the panelists, but I think this is an exciting session. I just wondered, do we have questions on the floor before, or do we want them to go? Are there questions on the floor? Can I see hands so that we can maximize time? So we have lots of hands, and I think we will take the first 3 questions for now, and then we will allow the panelists to respond, and then we will come back. I will ensure gender equity, gender balance, so I would like to see ladies also raise their hands in this first round. We have 1, we have 2, we had a hand, then I'll take, actually it's 3 sides, yes. I'll take the man in a, I don't know what color is that. I think it's a nude color.
Thank you so much. My name is Felician Luchagula from Pathfinder. Thanks to the moderator and the panelists. About 95% of Tanzanians own mobile phones. I'm just curious to know if there are any efforts at the central government level that leverages that high penetration level of mobile phones to improve access to services, especially in rural areas. Thank you.
So you directed this question to a specific panelist?
I don't know who is in the best position to respond to that question, but yep.
All will respond. So can I have the second question from you, Madam?
Thank you. My name is Doris, and thanks to the panelists. I have a question, and I applaud the efforts that have been made so far with the AFIA supportive supervision. But my question is, do we really think if we have a checklist, if we have a harmonized mentoring checklist, will that actually, how do we bypass the blanket mentorship? How do we bypass the one-size-fits-all mentorship? Because then if I go with a checklist, it's my institutions, it's my instincts that I need to mentor these guys on something, but how do I specifically structure my mentorship based on the needs of the health facilities and not the blanket mentorships? Thank you.
Thank you so much. I believe the question is for Chris Ogon. Is that correct? I will come to you in the second round. There was a question from Darrison, I think.
Thank you so much. My name is Darrison Andrew. I'm District Medical Officer of Sengerema. My question is to Professor Tumaini. In primary health care services, we adapted the use of GoToMIS because it was of invariable help. Our today's challenge in operations is data fragmentation. If the patient comes to OPD diagnosed with pneumonia, we will prescribe with amoxicillin or injections, parenteral. The same patient will be moving to dispensing window, either to the injection window. At the end of the day, the same information of a prescription will be transferred to LMIS, Integrated Logistic Management System, in the course of reporting and requesting drugs. But the same information will be transferred from GoToMIS to tour number 5, reporting book and tally sheet to develop a report at the end of the month. Doing this way, the record is increasing because the same staff will be running all of this. Can't we now minimize and make this system to communicate semi-automated because the time has come? In the same facility, we have around 5 systems: ILMAS, GoToMIS, VIMS for vaccine, and IMIES for nutrition. Because the same clients feeding them in all the 5 systems, can't we have one system operating, addressing the same cause? But the second thing, despite of investment in digital health, we have staffs whom I employed in the past 15 years. The digital system was not a part of their trainings. At the end of the day, we are facing problems to do with compliance. You see, can't we now digitalize our training programs that would be easy to adapt the culture when they're employed. And even though in the systems, they should not be left behind. Thank you so much.
Thank you so much, Dr. Darrison, for that question. I think some of the questions maybe could be high level for Professor Nagu, and the technical one, maybe Tanda could take it. But maybe just requesting the person who is operating the slide deck, if you can put the slide for Professor Nagu on the way forward. Somebody who is there on the, yeah, can you go to the, yeah, go down. Go down. Yeah, the way forward slide, go up, go back. Yes, so let this slide simmer. You can continue to look at it, and then let me allow the panelists to respond. Over to you, Ilomo, for the first question. I will take the second round, 3 questions.
Thank you very much, moderator. Basically, as a government, through Ministry of Health and PORAG, and even Ministry of Science and Technology, Ministry of Finance, together we are eager to use this opportunity of having a number of Tanzanians with utilization of mobile services. Basically, we know that for the 2024 statistic, almost above 70 million cellular active SIM card are up and running. And basically, we have like 25.4 million Tanzanians with the use of smartphone, mobile phone. So we as a government, we tried our best to make sure that we utilize that opportunity to make sure that our citizens benefit from the digital system that we are developing. My colleague Tanda has been presented regarding to personal digital data wallet. Basically, it's a solution which tries to give our patients how to be able to access his information whenever he or she is, so that whenever somebody owns the smartphone, he will be or she will be able to know the status of his health, issue the driving license and stuff. So this is a collaborative way, collaborative work that's governments with key private stakeholders like MNOs and staff. We are supposed to sit together, work together to make sure that we are coming with a robust solution that will cover the utilization of this mobile technology to make sure that our citizens are benefiting from the, whether it's low-end phone or a normal smartphone phone. We are trying to make sure that we explore that opportunity to make sure that they are benefiting from the use of this mobile phone. Thank you very much, Madam.
Thank you so much, Ilomo. Maybe if you can pass the mic to Chris Ogon, the question on mentorship. If you can speak of it or clarify it to the participant who had asked.
I think she was, the question was about the harmonization of the checklist.
Okay.
Yes. Thank you very much for the good question. Yeah, the issue of having a system, of course, is one of the issues having to harmonize the checklist. But as I've said before that we have almost around 300 checklists from different departments. So we have started the issue of harmonization. First of all, this year we have developed a checklist called Integrated Supportive Supervision for Checklist for PHC, which we designed according to 6 WHO building blocks, so that we avoid these verticalities. So you can see, I have said there are a lot of checklists. So we have started that to make sure that we don't have a lot of checklists, because we are confused. Normally we are confusing the users at the facility levels, that we have a lot of checklists, and sometimes it's very difficult to monitor them. So we have started the integration of this checklist, and starting with the support of UNICEF, we have developed a very nice checklist, which is currently being used by the CHMTs for supervision of the facilities. And that is one of the, we are starting the integration of these are a lot of checklists we have. So that, I think, is one of the things we are doing.
Thank you, Chris. If you can pass the mic to Tanda. Tanda, if you want to respond to the question that was asked regarding the duplication, multiple entry of data, then we'll allow Prof to come in last on anything she wants to say on that.
Okay, thank you very much. Yes, it's a really big cry, the data fragmentation. But I think soon we are getting over it, from the directives that was given out by Her Excellency Dr. Samia Suluhu Hassan, that up to December last year, all systems should be interoperable. And we have done our job. We're just waiting to go live. Currently, GOTOMIS and VIMS are talking to each other. As I've said, we are getting all the logistics, vaccine logistics from VIMS to GOTOMIS, and we are sending the reports to VIMS with the DHS2 through the HDU, our health data universal, which is our health information exchange. Currently, we are sending data to HDU. HDU, of course, will be sending data to DHS2. Of course, there were some changes that was made in February, so that hindered the whole process of sending data to DHS2. But currently, we are developing a paperless guideline. It's in collaboration between PORAG and MOH and other partners. We are developing a guideline for paperless, meaning from paper to less paper to paperless. So for you to go paperless, then you need to align with what the guidelines needs. So I think the guidelines will be out sooner, if not next month, but I know within this year, calendar year, then the guideline will be out. So that hectic will be out, but we also love to insist on data use. Because you're using only one module, the OPD module, and you want to go paperless. So we take you to less paper before going paperless.
Thank you so much, Tanda. Thank you, guys. If you can pass the mic to Professor Nagu. I think the question on why not a single system, what about the digital divide? We have healthcare workers who are left behind in terms of technology. If you want to say something on that and anything else, Karim.
Thank you very much. I hear you and I really feel you. And I think this question should go to all of us, and I think we should come out of here, all of us, with the same mind that we need to have one system, one report, one entry system, one reporting system. Sometimes this duplication comes because of different needs. And I think with the solution now is the digital strategy with standardization. And I think we'll come to automation. A lot of work is put there. I think I do not subscribe to multiple systems. So there's a lot of work that is going on to avoid this duplication and fragmentation. One of that is ELMIS and GOTOMIS. The other is National Health Insurance and GOTOMIS, because then you don't have to claim differently. You talked about mentorship, and I think that's really a valid point. There are standards that we have. Yeah, we have standards for infection control, and we need these standards. And that, I think, standards are good, and that's why we have checklists. And checklists are good, but with the use of information system that data is created from GOTOMIS, we could have a triggered mentorship, which is responsive to a certain problem that we've identified. And I think that's the direction that we want to go. It's not like supportive supervision as it is, but we're going to solve a problem that we've encountered, either from the central level or from the facility itself. Thank you very much.
Thank you very much, guys. Harry, you will have to forgive me. I've been told our time is up. We are 2 minutes past time. Colleagues, if we can make a very big round of applause for our keynote speaker and our panelists. And another one for ourselves for making it till the end. A big round of applause. And one for me for standing here in front of you. Allow me to ask Professor Nagu for one last thing, if you can hand over a certificate of appreciation to UNICEF for being a key partner and player in the digital health space for Tanzania and for primary healthcare and for Zanzibar. So I welcome Ulrika to come, and Wendy, if she's here, to come and receive this on behalf of UNICEF. UNICEF has been a key partner to the ministries, both Ministry of Health and PRORALG, in advancing digital systems in Tanzania. So a big round of applause for UNICEF, guys. Yeah, a picture moment would be nice. You know, it doesn't happen every day to sit next to Professor Nagu, so a big smile is good. Yeah.
I want to say thank you to UNICEF, not only for supporting us, but also for standing behind, systems and standards, ensuring there's one system for all. I think this is really very much commendable. Thank you, UNICEF, and we work together.
So guys, that marks the end of our session. Asanteni sana. Thank you, Professor Nagu. Thank you, everybody. And have a good day, everybody, and see you next year.